Coming on to the next discussion, I'll be dealing about immune keratitis, how to go about in an algorithmic approach. So the objective of this presentation will be how to differentiate between an immune and infectious keratitis, how to apply triaging questions or pathways so as to decide whether it is purely immunological or there is infective pathology underlying it, how to start first line therapy safely so that you get a response in the follow-up, and also know the red flag signs, when to change your treatment, when to stop steroid, when to start steroid with an antibiotic or antiviral. So immune keratitis is usually a pattern diagnosis. It's an non-infectious pathology with an immune-mediated inflammation happening in the cornea. It can be post-infectious, that is the body is having an immunological reaction to the antigen or particles secreted by the organism as such, or purely autoimmune diseases can have an immunological symptom in the form of keratitis. Post-infectious causes, the most common being marginal keratitis. Then there is flictannular keratitis also. Viral infections are prone to have immunological pathology, and immune keratitis is common. Interstitial keratitis, even though very rare nowadays, that has also been a cause of immune keratitis. Another most common is the one associated with systemic diseases, that is PUK. When you have ruled out all the causes, then in peripheral ulcers, our diagnosis becomes Murans. So what is the need? The need is because we are using steroids in most of these patients. But if there is an underlying infection, the use of these steroids can flare up that occult infection. And in PUK cases, inadvertent or non-judicious use can lead to perforation melt, and the need to referral might be delayed. Different set of systemic medications need to be started depending on the underlying etiology. For all these purposes, we need an algorithmic approach. So what are the clues from history that will help us in identifying what is the underlying cause? If the patient comes with a keratitis-like picture and has a definite history of trauma followed by eye rubbing or use of over-the-counter medications like steroid drops, think in terms of an infective pathology. The patient also has a history of contact lens wear, then also the infection is more likely to be, depending on the clinical presentation, likely to be infectious depending on the symptom severity. And contact lens can also give us peripheral sterile infiltrates that you have to differentiate clinically. Any previous history of similar episodes have to be checked. Blepharitis, if associated, then think in terms of marginal keratitis. If there is previous history of similar infection, you can have suspicion of HSV in your mind. Autoimmune disease, if it's positive in any of the family member, or if the patient itself is having recurrent oral ulcers or symptoms in that particular group of disorder, then suspect PUK or Murans. History of TB or syphilis, think in terms of interstitial keratitis. So the clinical features, when there is an infection, the patient will be more symptomatic. There will be severe pain, redness, discharge, lid edema, and blurring of vision. And on examination, we will be finding an epithelial defect with associated infiltrate. Abscess can be there. Feathery satellite lesions if it's fungal. There can be AC reaction, hypopion formation. Whereas in immune cases, the symptoms will be slightly on the milder side. One, because in HSV patients, the sensations are reduced. And another because as such, the reaction is happening in the stromal level. So mild to moderate pain, no severe blurring of vision. Most likely it will be in the periphery, so vision will not be that much affected. Patient will be complaining of a foreign body sensation, photophobia, and also the redness might be localized. And on examination, we will be usually seeing a peripheral arcuate infiltrate. There can be a clear zone with the limbus, minimal epithelial defects, and the larger stromal lesion will give us a hint that it is less likely to be infectious. So when a keratitis patient comes, if you get clues from the history, tailor your investigations in that way. If there is inconclusive evidence from the history, you will have to do a set of investigations to rule out which is the immunological pathology underlying. In that, you will have to also check for syphilis, TB, other viral infections which can have a immune reaction in the cornea. Basic blood investigation has also to be checked. If you suspect that still there can be some infectious components, scraping cannot be overlooked. You have to do scraping also. In spite of everything you do, you don't get a diagnosis and the lesion is peripheral, then suspect Murren's. So the peripheral lesions can be marginal keratitis. It's an immune reaction to Staphylococcus bacteria. It's a type 3 reaction in which immune complexes are formed and deposited against staphylococcal antigen in the peripheral corneal stroma. It can be in the form of infiltrates in the stroma, and if left untreated, it can coalesce and form a marginal ulcer. So its chain of pearl-like appearance is typical. There will be a 1 to 2 mm parallel to the limbus. The lesions will be, there will be clear margin of healthy cornea. Management is to have lid hygiene, hot fomentation, topical antibiotic ointment. Steroids are the best for treatment, but then also you have to give it under an antibiotic cover. Oral doxycycline for 1 or 2 weeks is also recommended. PUK, it's a destructive inflammatory disease of the juxtalimbal cornea. There is a crescent-shaped stromal thinning. There will be an overlying epithelial defect. Complex interplay of factors including both host autoimmunity and the particular features of the limbus. Because of the anatomical special features of the limbus results in PUK. So the etiology can be ocular cause and systemic cause. In ocular, infectious, non-infectious causes, and in systemic, there can be infections and non-infectious. This rheumatoid arthritis, ANCA-associated vasculitis, SLE, etc. are the commonest cause of PUK that we come across in our clinics. So how to manage? If you feel that it's purely an immune etiology and there is associated blepharitis, think in terms of marginal keratitis. There is no blepharitis, suspect PUK. Start the treatment, simultaneously send for a rheumatology evaluation also. If you feel that it's infectious, then send for scraping. If it is healing well, manage medically with the antibiotics. Non-healing, there is impending perforation. Also think in terms of PUK and also manage the perforation with surgical methods, which will be explained later. So if there is underlying systemic autoimmune diseases, local therapy can be given in the form of lubricants, as basic pathology will be severe dry eye. Give low dose antibiotics to prevent secondary bacterial infection. The role of topical steroids is controversial. You can start but keep on close follow-up. Topical cyclosporin is being studied as an adjunct role. In cases of where we can have to use steroids, can we use cyclosporin as an alternative? Systemic therapy has to be started. You can start doxycycline itself. Systemic corticosteroid or steroid sparing agents under the supervision of a rheumatologist needs to be started. Or if TB or syphilis is diagnosed, then treat systemic infection under a physician's guidance. Aggressive systemic immunosuppression is the treatment for PUK. Topical steroids, the role is controversial. It can increase the chance of perforation. Always send for rheumatology consultation in patients with high suspicion. In stromal keratitis, it can be either interstitial keratitis or viral stromal keratitis. Interstitial keratitis, the overall incidence is very rare nowadays. The commonest etiology still is syphilis and viral. Multiple organisms can have an immune reaction in the stroma. So the same thing holds true for stromal keratitis also, in interstitial keratitis also. There will be associated conjunctival injection, corneal haze, mainly stromal. Usually the epithelium is intact. There will be stromal neovascularization, and in certain cases, ghost vessels if old infection can be seen. If active, the treatment is topical steroids. If viral etiology is suspected, if sensations are less, or if the patient gives a history of past similar episode, start on antivirals. Treat the underlying systemic infection depending on the test results. Coming on to HSV, which is the most common cause of stromal keratitis that we come across in our practice. Out of all the types of keratitis caused by virus, immune stromal is the one, and endothelial ones are purely immunological. The rest of the ones, there is active viral multiplication happening in the cornea. So in immune stromal keratitis by HSV, it's a type 3 immune-mediated reaction. There is retained viral antigens in the cornea, which is causing the trigger for inflammation. So you can have an immune ring of Wesley also. There can be lipid deposition. There can be vascularization of stroma. Management is typical, the standard management is topical corticosteroid under antibiotic cover. If there is associated epithelial keratitis, you can give antivirals also. Always start for stromal keratitis acyclovir 400 milligram 2 times a day. The head study have given us the criteria for giving treatment for stromal keratitis. So in patients where only antivirals were used, they found that the addition of prednisolone definitely had a role in faster healing of stromal keratitis. So in stromal viral keratitis, treatment should include steroid drops under antibiotic cover. If there is epithelial component, start antiviral treatment also. In those patients who are already on steroids and prednisolone, they found that the addition of oral acyclovir 5 times a day doesn't have a role. But you can always put that patient on 2 times a day in a prophylactic way to prevent further infection. It was found that there was 41% reduction of any chance of recurrence in such patients. Endothelitis is another cause. It can be disciform, diffuse or linear. In all types of endothelitis, your treatment should be topical steroids, oral steroids if there is severe inflammation. Oral antivirals has to be started. It has been found that there is role for starting 5 times a day for at least 3 weeks in cases where endothelium and iris and trabecular meshwork is involved. Topical antivirals if there is overlying epithelial involvement. Secondary infection needs to be prevented with a broad spectrum antibiotic. So while using steroids, we have to find that it's a double-edged sword. There will be rapid response, patient will be responding well, but at any moment the virus can get reactivated and the patient can have epithelial disease and virus can invade and cause stromal necrosis. So always follow up the patient closely and you will have to keep the patient on long-term steroids. So the chances of cataract and glaucoma also needs to be taken care of. So pattern recognition, exclude infection, those are key. In PUK, systemic treatment is required, so you have to refer the patient timely. In HSV keratitis, give steroid plus antiviral under antibiotic cover, treat leads wherever necessary, use steroid drops judiciously for a better outcome. Thank you.